Honored to introduce Dr. Rose Nakasi. She's a leader in applying AI to transform global health. She's joining us from in Uganda. She's the head of AI Health Lab, where her team builds low-cost AI tools to diagnose diseases such as malaria and cervical cancer, often using a smartphone and a microscope. It is an honor to introduce Dr. Nakasi.
Thank you very much. Can you hear me?
Yes.
Happy to be joined by this group from the Global Health Catalyst. And thank you for the kind introduction. I'm glad that I was invited to speak to a very dear topic that we've been working on. And that is on AI in disease management and public health. If you could allow me to share my screen, trying to do that. All right. Can you see my screen?
Yes, we can.
Great. Once again, I'm Rose from Makerere University, from the Artificial Intelligence in Health Lab. What we literally do at the AI Health Lab is that we're trying to catalyze on the capabilities of artificial intelligence to address some of the pressing health challenges. And this is by leveraging cutting edge technology through interdisciplinary collaboration, and that is between computing and healthcare, so that we can collaboratively revolutionize healthcare delivery, improve patient outcomes, and ultimately make a meaningful difference, especially in the lives within the context where we apply these tools. Our vision is literally to transform healthcare through innovative AI solutions, and we don't do this in silos, but we collaboratively drive innovation in artificial intelligence research, and that is to effectively address and overcome pressing health challenges. And that is our core mission. When I was invited to speak about artificial intelligence in disease management and public health, this is the work that we've been working on, and literally what we are looking at in artificial intelligence in public health is how able are the artificial intelligence models able to analyze and interpret large health data sets in a transformative way, especially for public health and epidemiology. And that then lays the foundation for precision public health and medicine. So when you're talking about artificial intelligence in public health, we're looking at the large sums of health data sets from many sources, not only from a single source, but with the capabilities of artificial intelligence to be able to catalyze on all different sources of data and provide more meaningful insights out of it for providing better impact in personalized and at population levels. This then helps accelerate public health in ways around diagnostics, in ways of surveillance, but with the ultimate goal of shaping public health policies and implementation activities, so that at the end of the day, we have more improved public health services, especially to the patients. When you talk about what are the potential, where do we see potential of artificial intelligence in healthcare? We've looked at it, we've seen evidence of artificial intelligence providing self-management of chronic diseases at patient level. We've seen it assist people with cognitive disabilities to be able to maneuver around some of the difficulties they are facing, but also in clinical care teams where we're looking at it improve diagnosis and risk assessments. We're looking at it personalizing treatment plans, informing retrieval and visualization of healthcare, so that at the end of the day, the patients out there are able to get improved medical services. In healthy systems, again, around hospital administration, we've seen some use cases where artificial intelligence is supporting inpatient scheduling, so that before a patient comes to a healthy facility, their information is retrieved from wherever they are. And that then means that we are going to have better services even at the point of care where patients are coming in for admissions. We're looking at it supporting identification of fraudulent claims, especially around which patient came to a facility, how much have they paid, is there any fraudulent claim around the information they have provided. So artificial intelligence is able to provide some of the insights into identifying some of those limitations. In public health, we are looking at it in supporting disease surveillance, in monitoring air pollution, and those are all some of the potential use cases that we have seen artificial intelligence support in healthcare. Now, if we to look at artificial intelligence and how it can be utilized in public health, we need to understand the pipeline through which we are going to achieve the impact of artificial intelligence in healthcare, from the time of risk, looking at how are we going to be able to look at the deployment at the end of the day, and how artificial intelligence is going to support in public health. So we want to look at the pipeline where you're starting from requirements assessments. Usually this involves, and from our experience, to be able to identify what the problem is and where artificial intelligence can come in to support. I mean, this usually involves having talks with the healthy facilities to be able to understand, first of all, the problem, but also the requirements that are needed for you to undertake an artificial intelligence task within public health. I'll be going through each of these phases to give us an insight. But the phases involve requirements assessment. You need to look at how to profile data, because data is the fuel for any artificial intelligence model. And then once you've gotten the data and you've profiled it, then you need to look at how do you prepare data so that it is ready for artificial intelligence modeling. And that will then take us to the model selection. What kind of model is relevant for a given data source that you're providing it for? We shall then look at model evaluation, model deployment, and then at the end of the day, we really need to evaluate the impact of the artificial intelligence model vis-a-vis the expert knowledge, so that we are able to gauge how effective the artificial intelligence model is for any public health task. So with requirements assessments, really what we are trying to understand is what is the problem that we are looking at? Is it to be able to diagnose the disease? Is it around treatment? Is it around drug resistance prediction? So the first questions that we really need to ask ourselves is, what is the problem at hand? What question are we trying to understand, use to be able to apply any artificial intelligence model? And then how will this predictive model be used? So you really want to understand, okay, if there is a problem at hand and there are different models that are available, how will that then be used given a given task that you want it to perform? And then because medical data is very vast and enormous, so you really want to ask yourself, what are you trying to predict given the enormous amounts of data that is at hand, given the different models? What is the what is the end objective? What is the end outcome that you want the model to do? So we're really keen about trying to understand what is the model trying to predict before we even get into engagements with training. Then if you get to understand the task at hand, then you want to understand, okay, this is what I want to predict. What are the resources? What are the data resources that I need to be able to answer such a question? So then with the 3 questions above, then we are able to understand the kind of data that is necessary for us to run a task. If it is a classification task, then the kind of data that you're really looking at, if you're to do image analysis, then it will be image data. If you're trying to look at a regression task, what kind of data is necessary for such a task? So it is really important to understand the kind of data that we have that will answer the different artificial intelligence modeling tasks that we want to look at. And then after understanding that, we really want to be keen, how are we able to get the data? Especially when you're looking at health data, sometimes accessing the data is not easy. So it is always important that as you look at a given task, you really need to ask yourself, is there data availability for me to undertake such a medical task? What data might help us to make, because data comes in all different formats. So we really need to understand what data should help us to understand a given modeling task that is at hand. Because sometimes you have image data, you have structured data, you have text data, you have all these forms of data. So what kind of data is going to help you to make a very good prediction for a task that you need? Sometimes it might need a single data source, and sometimes it will need multiple data sources. So then understanding all that at hand helps you to transition through the different you need, because predict you consume. So whatever data that you give it, it will depend on that to be able to make the predictions and the outcomes that you're going to get at the end of the day. Therefore, model development may require data integration from multiple sources. And that's where I said that sometimes a task may require a single data source, but some other times it will require multiple sources of data. And then these multiple sources of data may not be the same formats. So sometimes it may be data that's coming from databases, maybe data that is coming from documents, maybe an open data set, maybe from social media. But whatever it is, you need to profile so that you understand the kind of data that is going to help you to achieve a given medical data task that you're looking at. But also during profiling, you really need to understand the quality. How are you going to assess the quality of data that you're going to feed into the model? Because we've realized that models are as good as the data they consume. Therefore, if you give it poor quality data, then there is a very high likelihood that data, if poor data is given to a given model, then the outcome is going to be as bad as that you've given it to. So we need to address potential weaknesses and understand the limitations of data, but also to be able to document how data quality was performed before we look at even the results that the model is able to profile. So that takes us to how do we prepare data for a given, machine learning task? Because here you're looking at data being as good as the data that you provide, as models being good as the data that you provide it with. So predictive models then would require data preparation, and that means that we really need to look at how data is prepared for a given data source. And I think I'll go into that detail when I look at the use case and how we've been able to do that. Under model selection, so once we have prepared well our data, then we are preparing it literally for a model training or an artificial intelligence algorithm training. So that then involves methodological and practical considerations. And then you need to understand the type of modeling that you're going to perform, given the kind of data that you have, but also the kind of task that you want to undertake. So then you would wish to ask yourself whether is it a regression task that I want to, perform, or is it a classification task? Do we have data for a single period or multiple periods or multiple sources of data providing input to a given model? These days, we usually have what we call explainability and interpretability. How are you going to perform interpretability of the results that you get from the model, or what the model is doing? And that sometimes brings us to an aspect of model explainability and model interpretability. And is it really important for you to go ahead, or the model is self-explanatory, that you might not need to go into the aspects of interpretability? We have already said that the better the data, the better the model. So the amount of data that you provide to a model is what would make it sometimes perform better. So how much data do you have to undertake a given task? Sometimes when you give little parts of data, that sometimes leads to models getting skewed, and sometimes they are overfitting or underfitting. So how much data do you need to perform a given task is one of the key important questions that we need to ask ourselves as we're looking into the model selection. Like we have said, that data sometimes comes unstructured, data sometimes comes with noise, data sometimes comes with all cases of limitations. That then gets to us asking ourselves that before we give a given data to a model, how are we addressing issues of bias, issues of missing values? Literally, how are you addressing issues of data gaps, so that at the end of the day, you're providing the model with data that is necessary to perform the right training that is necessary for that particular task. And then are there any important limitations on implementation? Because sometimes we are going to be faced with challenges of trying to achieve a given goal vis-a-vis the limitations, either from data or from the model itself. Sometimes you'd want to achieve better performance, but on the expense or as a trade-off of some other feature that is important. Sometimes it's because you're trading off for performance. Sometimes it's because you're trading off so that the model is able to fit either on a low-power device. So what are the potential limitations that you assume that the model will propel, especially when you're implementing it? Documenting and understanding all that is important to put it in the interpretation of the results that will come out at the end of the day once this is undertaken. In medical or in public health, that is very important, because then you're able to inform someone that as you take in these results as we take in this model, it is actually the reason why we're using this model is because it is able to help us achieve this, but there are some of the limitations that comes with it. For example, there are some models such as the SSDs that can sit well on a mobile device, because we really want to have a model sitting on a low-power device like a smartphone. But in terms of performance or in terms of accuracy, there is a limitation, because there is that trade-off that comes with the model. So as we're doing model selection, we really need to be keen about what are we trying to achieve and what cost does that come with. It could be in terms of computational resources that it's taking up that are not available, could be in terms of, you know, the platforms where we want the end model to sit. And it's always very important for us to understand all that. So once we have selected the model, then we can look into aspects of model evaluation. So in terms of model evaluation, we really want to be able to look at evaluating models from the different understandings. In this case, we're looking at evaluation of the models in respect to public health. What is the significance of the results that we're getting in terms of medical? And that's why for some of the use cases that we look at in public health, you really want to evaluate those against the expert interpretation, so that we are able to evaluate how good the model is performing. What error does it come with between the predicted and the actual values? Do the errors indicate systematic issues within the models? So all those need to be understood. In terms of classification, you're looking at what are the rates of false positives and false negatives. And this again goes back to the expert evaluations from the domain experts. What do they look at in terms of what the model has actually classified against what the medical standards look like? So that cost of false positive or false negative, and what is the implication of that if we are going to get a big error that's coming in from so many false positives? What does that imply, especially to a given medical task that we're trying to understand? And what is actually the right threshold? If I'm going to do a diagnostics for a given disease, what is this threshold that the model should try as much as possible to reach? And that again goes back to evaluating the model performance in terms of what the standards in medicine or in public health are vis-a-vis what the model is trying to imply, and what are the relevant evaluation matrices. I think that needs not to go unmentioned. What are the required matrices to use to match that particular standard or threshold that we're trying to look at? We shall look at all the different other ones that we have been able to use, but it's very important to understand all those ones we are looking at model evaluation, and what are the mechanisms that we can undertake to do model evaluation. So in terms of a given task, for example, if we are to take a regression task, what model evaluation really looks like is that model results will include a sign and magnitude of the estimated coefficients. And if we are to interpret that, then a low p-value indicates that an independent variable is statistically significant. So in terms of regression, what you're looking at is, are the results that you've gotten, are they statistically, significant? And then the measure of evaluation there will be a p-value. If it's lower, then that means that they are not significant statistic. If a low p-value indicates that an independent variable is statistically significant, but a high value would actually mean otherwise. So we need to understand what is the matrix to use and what does that signify according to the standards of evaluation. Then for a classification task, there are of course so many ways. One of those that I look at here is a confusion matrix that compares model predictions to actual results, because at the end of the day, what we really want to understand is that what the model has predicted, is it comparable to the actual values that come from the experts? And that is where you are able to determine an appropriate threshold for classification, generally depending on the cost of the false positives, all the negatives. And that brings us to specificity and yeah. So for training and testing, of course, once we are to look at the model training, usually it begins from how much are you going to give a model to train on, and how much are you going to give a model to test on, and then sometimes for the validation tests at the end of the day. So sometimes that evaluating out of the sample performance can prevent overfitting, and that indicates whether the model will generate effective predictions for the new data. So once we've got this huge amount of data sets, sometimes you need to have a split of that data into the training, validation, and test set instead of training a model on the complete data set. These are just dynamics of how we really look at the data so that we're able to understand how much of that data was used for training. Sometimes it's in the ratio of 60 to 20 to 20. Sometimes it's in a ratio of 80. But literally the rule is the training data sets should always be very sufficient compared to all the other sets so that the model is able to learn good examples out of the bigger set that you are giving it, so that if you now fine tuning it to a testing, then it is able to infer with some good level of knowledge understood at the training level. So with model deployment and ongoing evaluation, what we're really looking at is that what stakeholders need to approve a satisfactory model, especially in public health. You really want to approve a model that has been tested, that has been approved, that has been implemented in an environment with access to production data. And this actually comes from experience, because sometimes you get to train models in the labs or in silos without taking it in the real setting. It works very well, but once we take it to a given environment or to a different setting that actually is the real setting, the real impact setting, things just turn out differently. So as we're looking at model deployment and ongoing evaluation, we really need to implement the models in environment with access to production data. We really need to have front-end management or reporting, recommendation for potential enhancement and model refreshes. So this usually involves an iterative process, especially in medicine, that you need to go back and forth to have the model tested within the real environment where it will be eventually deployed, so that you're able to understand the settings, you're able to understand the environment under which the model will perform at the end of the day. And I think that is where the validation of the model actually happens, because models need sometimes to be trained. If it's a different setting and it was trained on a different given task, a given data set, then sometimes you need to refresh the models with to understand new variants of data that come out of the real environments where they are going to be deployed. And that's very critical. Sometimes they can be retrained on new data automatically, and that is, real update within the model itself. Or sometimes you may need to collect those new samples of data and incorporate them at the training phase of the model so that it is able to understand all those different dynamics. And that is why I come to re-echo that model development and deployment is actually fundamentally an iterative process where you have to keep new data, where new data can lead to changes in variable weights, because sometimes data that we maybe collected with a phone that was in 2018, now they could have phased out. So that means that new changes come in, and that means new data comes in, new data formats. And so those changes are really critical, because in an evolving health system with new data sets, new formats, models need to be upgraded, and those are opportunities to derive new variables, increasing or decreasing model performance is expected. So model refreshment is always very important. Now that brings me to, that is the pipeline through which we can be able to utilize artificial intelligence in healthcare. Of course, there are so many different angles I may not have looked at, but this is the standard pipeline. That now gets me to looking at the use case where we have leveraged artificial intelligence in healthcare, specifically for disease diagnostics. At Makerere AI Health Lab, we are keen at looking at artificial intelligence to be able to handle some of the pressing health challenges that we face actually in Uganda. And one of those cases is malaria, which is one of the highly big burden public health cases that we have. Not only malaria, but when you look at cases such as cancer, cases for tuberculosis, all those constitute part of the bigger public health burden, not only in sub-Saharan Africa, but as well as the globe. Specifically for malaria, of course, it's gold standard, or what I would call the confirmatory test of it for disease diagnosis is by the use of the microscope. So what was the motivation for this particular use case in public health is that we literally have very few skilled experts in our healthcare system. And what then that means is that most of the patients will either miss a diagnosis or they will wait longer before they actually get a diagnosis. And that means that even the way they operate the use of the microscope, where you have to strain your eye, an expert has to strain their eye to be able to look out for those pathogens in the blood sample, is literally straining. And that's why actually WHO recommends them not to be able to look at more than 30 patients or 40 patients in a day. But then when it gets to some of these high burden diseases such as malaria, you can find that in a day at a given health facility, patients are over 1,000. And if we to look at, first of all, the few experts, and in some facilities, especially in the remote parts of the country, we don't have any. So that means that if we to look at the confirmatory test, most of them will not. And when you look at the alternatives, which are like the RDTs, especially at low parasitemia, they might miss out to be able to capture the disease. So this was the motivation for the utilization of artificial intelligence in healthcare, because what we really literally did was how can we be able to, utilize artificial intelligence against the gold standard, which is by the use of the microscope. How we're doing this is we have developed a 3D printable adapter that we attach on the eyepiece of the microscope to be able to capture the image on the smartphone. And then we utilize artificial intelligence in the background to be able to understand the characterization of the parasites or any other object within the image that can speak to, for example, malaria diagnosis, be it parasitemia determination. So literally what we capture is this image. So the artificial intelligence task we are trying to undertake here is an image analysis task. And what you see in the blue bounding box is the parasite that we are trying to look at. So we are training the model to understand the characterization of that object, which is actually the parasite, characterized by a red dot and a chromat circle around it. So we have collected so many samples of these images, and we're collaborating with different health facilities in Uganda to curate that data set. Through a classification task such as this, they give us the characterization of what the positive samples mean, what the positive samples are. So in this example, what you're looking at, we were looking at a classification task to tell whether a given patch is either a positive, meaning that it's a parasite, or a negative, meaning that that particular patch didn't have any malaria parasite. So in this particular task, we used a data set of over 1,118 images, not so sufficient, but at least good enough to give us some good analytics. And then we utilized an artificial intelligence, a convolutional neural network model architecture to be able to understand the characterization of the parasites that we are looking at. The good thing with deep learning is that you don't have to feature in near the features. It learns those features automatically from the data. So once it's given data that's characteristic of the objects that you really want it to understand, then it can be able to provide an insight. And in this case, what we're looking at is what the CNN model was able to perform on an image for malaria. These are detected objects for Plasmodium on the left. Within the red bounding boxes are what the model predictions did, and the white bounding boxes are what the model experts did. So we had to do an evaluation of the model against the expert annotations, and indeed it provided good insights. We also had to generalize it against other cases. For example, for TB on the right, you're able to see that again, the CNN model is able to infer very good performance on the TB bacilli as comparable to the expert lab technicians who did the white bounding boxes for this case. We also had to look at other tasks. For example, in this particular example, we are looking at a case for doing parasitemia determination, where then the artificial intelligence task was to be able to understand the detection of both the parasites and the white blood cells. Literally, what I mean is this. So here the model is able to infer, to detect both the small objects, which are the parasites, and the white blood cells. And again, using MAP, mean average precision, as the evaluation matrix, again, we are able to see the performance of different models. So in this, you're able to see that given a given model, for example, the FASTA CNN was able to give good performance, but the SSD MobileNet, because we needed this model to sit on a mobile phone, there were some trade-offs. The MobileNet provided lower inference in terms of the map, but it was able to provide a trade-off that it was able to sit on a smartphone, because the FASTA CNN, which literally is a heavy model and computationally intensive. We have been able to look at different other use cases for artificial intelligence, but given time, this particular case is where we're looking at artificial intelligence supporting in malaria disease surveillance. This particular use case is important because we are able to combine data from different sources, not only image data, first of all, to provide better inference on the image analysis, because if I detect malaria with an accuracy of 0.5, that means it is just at the threshold. So there is a high likelihood that probably it's a false negative. But when I include in data, for example, location, because malaria is a vector-borne disease, then it is able to provide me with better inference to understand that if a patient was diagnosed through the ocular application with a 0.5, and then I provide the information about the location in terms of what was the climate, what are the locational characteristics. Then if they actually speak to features that provide higher prevalence for malaria, then with my 0.5, I can be able to improve that performance and level of confidence that indeed the patient who came in with a detection of 0.5 is actually rightfully having malaria. We've been able to use it in different other use cases where we're looking at cervical cancer detection. We're also looking at it in terms of using artificial intelligence to actually communicate the impact of artificial intelligence. For example, how we're using it in the communities is that most of the people in our communities don't even understand artificial intelligence, because sometimes it comes in English and people don't understand English, and we need to have this communication provided to them in their local languages. So we're creating a data set that is supporting the way we can be able to sensitize people about the impact of artificial intelligence. So those are some of the few use cases I can just knock off, but there are of course so many. This is just to provide evidence of how we're utilizing it in our settings. As we look at artificial intelligence, we need to look at guiding principles for using artificial intelligence, especially for us in our context, in our context in LMICs, where people believe in technologies that they have, embraced. So we need to look at artificial intelligence with a people-centered kind of attitude. Literally, we went to the healthy facilities with this notion that, oh, we are building these fancy tools for you. But when you got to the field, it was a different story. They really wanted to understand what is artificial intelligence, how are they going to use it for teaching, how are they going to use it to, provide, to relieve the way they look at the image. So that kind of feedback has helped us, because we are interacting with them from the co-creation, co-designing with them to understand what they really need. And that's why as you're thinking about artificial intelligence, it's always important to understand that this tool should be people-centered and they are the ones to drive it. It should be ethically grounded. It should be transparent. There needs to be data protection, scientific integrity, open shareable, non-discriminatory, human control technology. I'm just going through these just for the case of time. Their key priorities for successful use of AI. AI does not just sit in a silo, but there are so many systems that control its implementation to the deployment phase that we really want, because there are governance structures that we really need to think about. There is research that goes on from the universities and laboratories. There is a whole system of healthcare delivery, and how are we going to integrate that so that they sit together, not just interrupting the entire public health sector, but having a very good seamless procedure for integrating artificial intelligence in healthcare. But again, there are perils for consideration, because as we look at consideration of AI in healthcare, there are some limitations in our context. Sometimes it's the data accessibility. There are variations in data capture. There is a lack of an enabling environment of government policy and developed open discussion, skepticism that comes in sometimes when you go to healthcare facilities. Sometimes they even have fear that they are going to lose their jobs. So all that dynamic limits the quick integration of artificial intelligence in healthcare. But those are some of the things that we have to critically keep an open discussion about and keep engaging with them, so that we see the good impact of AI in healthcare. But there is a very good scope for AI in public health. However, it's still in its infancy, especially in our context. As we maneuver into having it integrated, we really need to address some of those various changes. We have to keep these open discussions going, so that there is appreciation, there is evidence that we are creating, but with the end goal that whatever we are doing, we improving we are looking at better improved outcomes, especially in the healthcare systems in our context. I want to thank you.
Thank you very much, Dr. Nakasi, for that great lecture. We have a few questions in the chat. If you are ready, we'll go ahead and get started with those. So the first question is there a good example of how AI has been applied successfully in public health, and can we use AI to predict disease outbreaks?
Yeah, I think I've presented one of the use cases that we're working on. Of course, there are so many good examples of AI and how it's applied successfully in public health. These days, we see so many LLMs are transforming very fastly and disrupting the way communication is done in public health. We have AI-assisted, chatbots in public health. Our use case specifically is improving the way diseases are diagnosed, the way diseases are surveilled. We're also looking at mental health application that can support especially adolescents in our universities to be able to maneuver some of the challenges they face. So yes, I stand to say that they are very good. There is a very good evidence base, though it is still in its infancy stage, like I highlighted. We just need to keep the momentum up and to show evidence that indeed artificial intelligence can support in the healthcare system. Wherever there is a wherever we can be able to generate data, that's a very good use case for artificial intelligence, which you can be able to leverage on.
Thank you. The next question is, have the AI tools you've developed for diagnosing malaria and cervical cancer been validated or tested in clinical settings, and are they currently available for use or being scaled for broader development?
Yes, we're collaborating locally here with the Uganda Cancer Institute. We collaborate with them from the time of data curation, understanding the different challenges that they have. We have just developed our paper is under review right now, because we've already published a prototype system for cervical cancer detection. We are still at the pilot within Uganda. Once we go out to have a scale, I believe that this is technology that can actually disrupt the entire histopathological disease challenges, not only in cervical cancer, but also other cancers. And we're still really open to, collaborations to scale this across.
Thank you. The next question is, how do you ensure accuracy and reliability of AI models in clinical environments where infrastructure may be limited?
Yeah, that's a very good question. So from experience, we've had challenges where some environments actually do not have internet connectivity, because the first kind of models that we created were those where an image would be, broadcast over the cloud, and then inference made wherever there is internet connectivity. But in some of our settings, there is already that infrastructure limitation. So what we're trying to look at is that, can we even have an offline model that can work, even to provide insights? Because literally what we're looking at is that at the end of the day, we have to have an expert on ground to be able to approve. But there are different cases where we have context and there are no experts on ground. There is no internet connectivity. And what really needs to be provided is an offline application. So we're trying to maneuver that for our mobile application. We have both an online and offline application to at least provide that insight limitations. We're trying to, as much as possible currently, and that's what we're doing currently in our pilots, to do a very good evaluation to understand the pipeline and audit at every step of the way that we're working on, to understand that whatever is provided, especially for the offline where there is no expert on ground, even if the results may not be reliable, but they should be interpretable, that whatever you're seeing as a result is because of A, B, C, D. So those audits are some of the things that we're putting in place to be able to know that we are doing a data audit, we are doing a model audit, and explainability of the results at the end of the day, because that is very, very important.
Thank you. The next question is, what type of infrastructure or policy support is most critical to scaling AI-driven diagnostics in Uganda and beyond?
Yeah, so in most of the sub-Saharan African countries, policies are just getting to be developed. In some cases, for example, in Uganda, Ministry of Health currently has a digital public health framework for use, but not specific for artificial intelligence. It's very critical that governments take these initiatives as soon as possible. But even in scenarios where there are no policies or regulations in, I know that WHO has already provided some global policies to follow. So if we can be able to adapt to some of those that are available and then contextualize them to our settings, I think that is very key. But also being open to have our governments or our regulatory bodies open to seeing the impact of the evidence that is created, especially for the artificial intelligence solutions, because once we create a good base of evidence, that is where we shall see the impact of deployment of these solutions in the healthcare facilities. So what really needs to take place is that governments and regulatory authorities need to step up, get into these conversations, but also adapt, be very quick to adapt, at least get an evidence of it and understand and appreciate it, because that will be the driver for the overall development of these policies once we create and appreciate the good base of the solutions that are being generated. It requires openness, open communication, I believe that's the better way.
Thank you. The next question is it possible to access the AI tools your team has developed? Are they publicly available or being distributed through specific channels?
Yeah, so our page is open at the Makerere AI Health Lab. We also have the Ocular specific project lab where some of our results are already communicated. We have some public data sets available, again, through our platform. So I do recommend that we can have, and whoever might require this could have a follow-up engagement through my email, or literally to reach out through our pages to look at the work that we're doing, and appreciate it.
Thank you. The next question, in your research, what are the main challenges you faced in using healthcare data for AI development, specifically when it comes to protecting patient privacy and ensuring data security?
Changes, right? In protecting patient data, right? Did I get that correct?
Yeah, in terms of
So
protecting patient privacy and ensuring data security.
exactly. So one of the key pertinent steps to undertaking any health data research is for us to do what we call an IRB, because what that then specifies is how are you collecting the data, how is patient data protected. What we are currently doing is that we do provide anonymization protocols within the data that we collect to not be able to reveal patient information. And also basing on the task that we are undertaking, we are keen on putting the patient out of the models so that we're able to understand whatever we're trying to look at is literally anonymized and encrypted. Whatever is sent over is just an image with just, we usually use PIIs to anonymize the data. And that means that we leave out any data or demographic that gets back to the patient in ways of protecting their data identity. I hope that brings out the question, the solution to the question that was asked.
Yeah, I think that is great. Thank you. And then the next question, with the field of AI in global health still developing, what criteria should we use to critically assess the relevance of AI-focused research publications? Dr. Nakasi, I think you're on mute.
So the question was how to effectively assess and evaluate AI publications. Literally what I think what should be based on is, first of all, what is the standard? What is the medical standard? That is available, because we know that and how that then relates to the medical field is what I think one of the key things that we need to look at is what has the model performed, what is the artificial intelligence model performing against the known standard. Because if we begin from what is available, how can we just oppose that against what the model is performing? That is one good criteria. Again, to look at the evidence that is already there. I mean, there could be evidence that is not in malaria, but there is evidence that has been provided in tuberculosis. What is the evidence across the different other domains that are available, so that we can be able to, bring that and evaluate that against the already existing criteria. In scenarios where there is none, I think the idea is for us to even create evidence. What is the evidence? So long as there is evidence that is traceable, evidence that is explainable, evidence that is following at least the standards, because we have the FAIR standards of evaluation for AI models. And I know that WHO has already put up guidelines for evaluating artificial intelligence solutions in healthcare. So if we can be able to audit at every level of those evaluation matrices, evaluation frameworks, especially in scenarios where we don't have yet evidence within that particular field, then we can try to ask ourselves against the criteria that has been set by WHO. But it is also important that at least there is evidence that has been created to start to kickstart all that process.
Thank you, Dr. Nakasi. I believe that was our last question. So again, thank you for giving us a compelling look into how AI is being used to advance disease diagnosis and strengthen healthcare systems in resource-limited settings. Thank you
Thank you very much.
to all our participants for being part of this session. Please remember to complete the feedback survey, which is in the chat, to be eligible to receive your certificate of participation at the conclusion of our course. And we look forward to seeing you all again next week. Thank you.